My name is Alistair, and as I'm sure you can see from my PowerPoint, my clinical question was, should providers initiate a hypocaloric diet for obese patients in an acute care setting? So I want to start a little bit and talk about just about the relevance of the clinical question. So obesity defined as a BMI of over 30, of which approximately 42.4% of Americans meet the criteria. In addition, obese patients are at increased risk of complications, specifically to the cardiovascular, respiratory, endocrine, neurologic, musculoskeletal, GI, reproductive, and integumentary systems. They're also at an increased risk of cancer, which increases the probability of being admitted to a hospital setting. Furthermore, obese patients who are admitted to a hospital have a higher risk for worse outcomes and utilize more resources than non-obese patients, according to Fusco et al. 2017. Even with the increased risk associated with obesity, little is done to address it within the inpatient setting, according to Srivastava et al. 2018. So only about 6% of obese patients had obesity addressed in their care plan, and only about 37.5% had obesity documented in their chart. Yet, even so, there's a clear disconnect between how prevalent obesity is and how much is documented. But even with obese patients, research has indicated that of obese patients, 86% wanted to lose weight, 64% wanted a dietitian referral, and 62% believed that their physician could help with their weight loss journey, according to Davis et al. 2006. So there's a clear need for interventions within the inpatient setting for obese patients. When I first considered this clinical question, my initial assumption was, since obesity causes a myriad of problems, obesity should be addressed in the inpatient setting, regardless of the admission cause. And the first step towards that can be, a calorie restriction. Some assumptions that I held as the barriers why this may not be occurring already is that, perhaps patients may need a sufficient meal to assist with the body's response to stress. Patients have the choice regarding what and how much they consume. Restricting patient calorie intake for the short amount of time they're in the hospital will not have a major effect on weight. The hospital inpatient setting does not have the capabilities to restrict calorie intake for each individual patient. There are greater risks that should be prioritized other than restricting calorie intake if patients are being admitted to the hospital. Nothing is preventing a patient from having a family member or friend bring them additional high-calorie foods, and that calorie restrictions may cause additional mental or emotional stress to the patient. So we know that obesity is prevalent, and we also know that it's not being documented and interventions aren't being put into place in the inpatient setting. So why? Srivastava et al. 2018 surveyed a group of medical residents, and the reason they chose residents is because, according to Golden et al. 2022, attendings typically see patients only during rounds, whereas residents see patients at various times throughout the day. So Srivastava et al. 2018 found that residents believe obesity to be a serious medical problem, and they're able to identify obesity when they see it. So 98.5% of residents reported obesity to be a medical issue. 89.5% of medical residents knew BMI criteria for obesity and were able to correctly identify a class 2 obesity phenotype. So even though they're able to identify it and know that it's a problem, just remember that only 6% of patients had obesity addressed in the care plan. So there's a clear disconnect between what they know and what's being done about it. Srivastava et al. 2018 also found that more than 1/3 of physicians believed obesity was best dealt with by non-physicians. In particular, 33.9% of residents suggested dietitians should manage obesity care. However, those referrals are not able to happen unless a referral is made. So if the physicians aren't documenting the obesity in the chart, a referral is probably not going to be made. So it goes into the circle of no one doing anything about it. Srivastava et al. 2018 indicated that residents reported reluctance to document or treat obese patients due to lack of treatment options in the inpatient setting, due to patient sensitivity to the topic, and due to a lack of obesity-related questions available in the medical health record. So one of the biggest complaints of residents is that there was not much that they could do within the inpatient setting to deal with obesity. So I looked it up, what can be done? So Chobin et al. 2013 recommended that a nutrition assessment and formulation of a plan should be implemented within 48 hours of admission of all patients, regardless of whether or not they are obese. Chobin et al. 2013 and Dickerson et al. 2022 found that evidence supports a hypocaloric, high-protein diet for obese patients within inpatient settings. In particular, there should be a trial of a hypocaloric, high-protein diet that consists of 50 to 70% of estimated energy requirements or less than 14 kilocalories per kilogram, supplemented with an increased protein level of 1.2 grams per kilogram of protein of actual weight, or 2 to 2.5 grams of protein of ideal body weight. And that's according to Chauvin et al. 2013. The reason why you need that increased protein level is because in a starved or hypocaloric obese patient, energy expenditure is lower for fat metabolism and higher for protein metabolism. In essence, more protein is being burned off in a starved or hypocaloric obese patient than fat is. And that's according to Al Dorsey et al. 2022. While that's the current recommendation, it's important to consider that each diet should be individualized and should be consulted with a multidisciplinary team that's able to assess the patient individually and ensure that no other micro or macro nutrition deficiencies are occurring. Dickerson et al. 2019 found that hypocaloric diet with low protein levels is actually associated with worse clinical outcomes. So when you have low calories and lower protein, it showed a worsened 60-day mortality rate as opposed to if it were supplemented with a high protein level. Contrast that, a hypocaloric high protein diet has been associated with improved clinical outcomes according to Dickerson 2019. So according to Dickerson 2019, that low calorie high protein diet showed a decreased length of ICU stay, decreased duration of antibiotic therapy, and a trend towards decreased ventilator days and hospital length of stay. Chauvin et al. Also found that a hypocaloric protein high diet was shown to be at least equivalent to that of a eucaloric high protein diet. So there's no recorded negative or downsides to a hypocaloric high protein diet. So now that I knew about some of these interventions that could be made, I applied Swanson's theory of caring and healing to it. So some major assumptions of Swanson's theory of caring and healing is that the application of the 5 processes, which I'll talk about in a sec, will contribute to a sense of comfort in the patient, which is achieved when the patient feels capable, valued, hopeful, understood, and safe, according to Swanson's 2020. Swanson also believed that caring is correlated to healing. So the 5 processes that we'll talk about in a sec include knowing, being with, doing for, enabling, and maintaining belief. While they all complement one another, they are able to occur separately from one another and can still contribute to a sense of comfort in the patient. The Swanson theory of caring and healing applies directly to the proposed clinical question. The theory strives for the patient to feel comforted and for the nurse to best position the patient for healing. Even if once the patient leaves the hospital, they resume unhealthy eating habits, if we truly care for our patients while in the hospital, we should advocate for that hypocaloric, high protein diet as it will put them in the best possible position for healing. So this is my implementation of the Swanson theory of caring and the knowledge that I learned about hypocaloric diets. So the first process is going to be the knowing process. So when the nurse takes the time to truly know the patient, they're able to understand and be compassionate towards what the patient is going through. The nurse or provider must attempt to understand the issue through the eyes of the patient and understand what led them to their current situation and any barriers or support that they have or will have when dealing with their current issue. This is a super important step because it can identify that obesity may be a contributing factor to the patient's current admission and may get to the root of the behaviors or emotion that have led to the current situation and the patient's obesity. When the nurse takes the next process is going to be the being with. So when the nurse takes time to be with the patient, they are present with the patient to identify emotions and feelings regarding what they are going through. These emotions or feelings may also be contributing to the obesity or to the patient's admitting diagnosis. For example, if an obese patient is admitted with unstable angina, which obesity can contribute to, it may cause a sense of fear, anxiety, or paranoia in the patient. As such, the nurse is there to pick up on those cues and understand why the admission matters to the patient. The third process is going to be the doing for process. In this process, the nurse uses what they have learned and picked up on to do for the patient what they themselves would want done for them if they were in a similar situation. This would essentially be the implementation stage of the nursing process. At this point, considering what is known about the risk associated with inpatient admission of an obese patient, it is the nurse's responsibility to identify the patient's obesity, consider everything that was learned during the knowing and being with stages of the process, and recommend an individualized hypocaloric, high protein diet to the provider. In recommending the diet to the provider, the nurse can explain why the proposed diet is in the best interest of the patient and can ensure that the patient is being put in the best possible position to heal. During the enabling stage, the nurse provides education to the patient and hopefully their family about the implementations that are being made and the reasonings behind it. As was previously mentioned, there's hesitancy to talk about obesity with patients. However, if we truly care for our patients and want to provide them with the best opportunity to heal and prevent further issues, we must educate them about the risk of obesity and ways to manage it. Education should also be followed up with referrals to weight management clinics and programs that allow for outpatient support, accountability, and depending on how well integrated the system is, hopefully opportunities for follow-up by the nurse or provider implementing these changes so that the patient continues to receive support and belief outside of the hospital. And then the core process is maintaining belief. It's central to the process. If the nurse and provider maintains belief that the patient is capable of healing, even with the diet modifications, and that the behavior changes addressing obesity can be continued outside of the inpatient setting, it will instill a sense of hope into the patient that they can continue this outside. This hope can also hopefully facilitate a sense of maintained belief by the patient, like the patient maintains belief in themselves that they are able to continue the implemented behavior changes outside of the inpatient setting. If all 5 of these processes are achieved, then the hope are that the patient will feel valued, hopeful, understood and heard, safe and comforted, and will feel capable of healing and continued behavior change. So, application of the theory to the clinical question. As nurses, the primary goal should be the healing of the patient, right? That should be the #1 priority. Swanson 2020 believes that healing is directly correlated with comfort. So, as previously mentioned, if we truly care for our patient and have this difficult discussion with them regarding their weight and implement these changes, it will put the patient in the best position to heal and continue, hopefully, with these reduction of risk associated with obesity. Now, does this theory apply to the clinical question? Yeah. It allows the nurse the opportunity to form a caring relationship with the patient that facilitates and promotes healing. This theory can also continue into the outpatient setting, and the maintenance of hope can help propel the patient to continue with obesity treatment, along with and given that we provide outpatient resources and support. This theory would likely be specific to nurses. As I'm sure you can imagine, it would take time for the relationship to progress to a level where a provider can truly encompass all 5 of these processes. As such, nurses have the time and ability to form these bonds with patients and facilitate change via advocacy for the recommended hypocaloric high protein diet. Now, I want to cycle back to those assumptions that I talked about earlier. Is there evidence supporting or contradicting the initial assumptions? Let's find out. So the first one, patients need a sufficient meal to assist with the body's response to stress. This is true, but as mentioned, evidence suggests that a hypocaloric, high protein, individualized diet results in better or the same clinical outcomes as a eucaloric, high protein diet. The second one, patients have a choice regarding what and how much they consume. Patients should always have the choice as to what is best for their own body. That's part of medical and bodily autonomy. However, in facilitating the enabling and maintaining belief aspects of the theory, the hope would be that the patient buys into the plan and gains a sense of confidence and self-belief that they can heal and thrive even under and even while being on a hypocaloric, high-protein diet. If that buy-in occurs, then it's essentially a patient-centered intervention that the patient chooses to participate in. Third, restricting patient calorie intake for a short amount of time during the hospital will not have a major effect on weight. Even if the patient chooses to revert to an alternative diet upon discharge, it is still the nurse's responsibility to treat the patient in the most caring way and in a manner that they would want to be treated. For obese patients, the evidence suggests that a hypocaloric, high-protein diet is the standard of care. So even if the minute they leave, they go back to an unhealthy diet, we should still promote the healthiest behaviors that we know. 4, the hospital inpatient setting does not have the capabilities to restrict calorie intake for each individual patient. While the evidence that was reviewed did not specifically confirm or deny whether the inpatient setting has those capabilities, given that various articles discuss hypocaloric diet implementation, it suggests that the capabilities do exist and that it can be done. 5, there are greater risks that should be prioritized While there may be more urgent risks that should be addressed other than obesity, the evidence is clear that obesity can contribute to numerous conditions that can prolong length of hospital stay and clinical outcomes. As such, if we want to promote a caring environment and promote healing, obesity should still be addressed within the inpatient setting. Nothing is preventing a patient from having a family member or friend bring them in additional high-calorie foods. Yeah, nothing is preventing them. But hopefully during that enabling process, when we educate both the patient and family and friends, we can educate them about the importance of the intervention changes, and the family and friends can become active members in the plan by supporting the patient and maintaining belief in their ability to maintain the hypocaloric diet and heal. And then lastly, calorie restrictions may cause additional mental, emotional stress to the patient. Research indicates that physicians are hesitant to speak to patients about obesity because of the sensitive nature of the topic. However, we must always go back to a caring environment that promotes healing. If we want to put the patient in the best possible position to heal, we must address obesity and treat it within the inpatient settings. If it does cause emotional or mental distress, that's where a multidisciplinary team could come in, and perhaps we can refer them to psychological support. But we still need to address these if we truly care for a patient and want them to heal. Then lastly, implications for nursing practice. So if nurses are able to implement this theory, the belief is that it will create an environment that fosters care while addressing and dealing with obesity, a major contributor to various conditions. During the during for stage, the primary role of the nurse should be, like I said, an advocate. Once obesity is identified, a hypocaloric, high protein diet should be recommended, along with a personalized consult with a dietitian who can assess for any other metabolic needs and any other multidisciplinary team needs that the patient has. This process will be one that takes time and develops as the nurse interacts with the patient. As such, education will be required so that the nurses are aware of how the theory is applied and how it can be implemented, but it's likely something that will be learned by experience rather than being taught. These are the references that I used throughout my research, so please feel free to comment if you have any questions. Thank you.